This lecture will discuss medical nutrition therapy for neurological disorders. So let's talk a little bit about neurological disorders. So there are more than 600 diseases and disorders that can affect the nervous system. The nervous system is the most complex system of the body and serves to coordinate the action among all components of the body. Nutritional considerations are integral to effective medical and clinical management of these. There are two major divisions of the nervous system. So we have the central nervous system, which consists of the brain and spinal cord. The function of these organs is the processing of sensory information and responsive motor signals. The second division is the peripheral nervous system. So this is nerves leading to and from the central nervous system, and their function is the transmission of impulses between the central nervous system and peripheral organs. So within the nervous system, we must determine where the defect or lesion is in order to make a diagnosis. So depending on which tissue or organ is damaged, will determine the symptoms. So this can be in the muscle, the nerve, spinal cord, or brain. Nerve tracts coming to and from the brain cross to opposite sides in the central nervous system. So a lesion in the brain that affects the right arm is actually on the left side of the brain and vice versa. So if there's any problems moving, for example, your right arm, your right leg, your right fingers, that's all the left brain. And if you have problems moving your left leg, your left arm, the left side of your body, that is the right side of your brain. The location of a lesion can often be determined by observing stereotypical abnormalities. So here we have basic functions of the cranial nerves. So there are 12 cranial nerves. And so this tells you which cranial nerve is responsible for what function. So for example, cranial nerve 1 is responsible for smell. So if you are smelling things that others are not smelling, or you have altered sensations of smell, then that means there is some kind of lesion, damage, or defect with the first cranial nerve. The second cranial nerve is the optic. So again, if there's damage to your optic nerve, right, to the second cranial nerve, then there would be changes in vision. So again, if you're seeing things that aren't there, if you're having trouble seeing, etc., again, if this is a physical problem and not a psychological one, then again, this is damage to the second cranial nerve. Now here, instead of looking at the cranial nerves, we're actually looking at the portions of the brain. So we have the frontal lobe, the parietal lobe, temporal lobe, occipital lobe, and cerebellum. And so again, each portion of the brain is responsible for different functions. So again, damage to the brain will affect those functions. And here you can see, so instead of just looking at the outer lobes of the brain, we're actually looking inside the tissue where again, so we can see different organs, so here in different portions of the brain. And so here you can see it is color coordinated. So the one benefit you have from not looking at the slides and instead being able to look at the recording is you can see that it is color coded for looking at which portion of the brain controls which functions. So the frontal lobe is for more complex activities, thinking, planning, emotion. Again, it's typically described that the frontal lobe is really personality, so who you are as a person. But we can also see, so defects or damage to the frontal lobe can result in depression, mania, and changes in personality as observed. So the case study, the original case study for that is Phineas Gage. The parietal lobe, so the ability to focus, logical thinking, and experiencing of pain. The temporal lobe controls memory, speech, and hearing, and so may be affected by things, for example, such as Alzheimer's disease and stroke, which affects the patient's ability to speak. The occipital lobe, so at the back of the skull for vision. So if you've ever been hit in the back of the head and seen stars, right, or if you've ever fallen and hit in your head when you slipped on something in the kitchen, etc., right, that's because, right, you took a blow to the occipital lobe. And at the base of the skull, right, we have our sense of smell. So again, anosmia, which is a lack of smell, or hyperosmia, so increased sensitivities, or dysomia, so altered or distorted smells. And the cerebellum and brainstem, so again, may obstruct ventricular system of the brain, which is the ventricles or the fluid and blood flow to the brain. And so damage, right, can result in what's known as hydrocephalus, or water on the brain, due to increased intracranial pressure, which is so because the flow of liquid or fluid in and out of the brain is altered, This can cause fluid to build up in the brain, increasing the pressure, which is very dangerous. Here again, so we can see the nerves. So here we have the spine, and so you have 8 cervical nerves, 12 thoracic nerves, 5 lumbar, 5 sacral, and the coccygeal. And so again, what we're going to take a look at is, so depending on where damage occurs, so if there is an injury, is going to affect where the damage is on the spinal column, and then of course the nerve that runs through that spinal column. And so here, so if you've ever seen, or if you've watched any television, so for example, they recently had on The Bone Collector, so they did which I know is like an old Denzel Washington movie, but then they've redone it as a TV show. In which case, so you can see, if somebody is completely paralyzed, and so we'll talk about that a little bit later in the lecture, but you can see in essence what they are able to maintain, or what functions will still function, depending on where the severity occurs. So for example, if somebody has a T1 fracture, so that is thoracic vertebrae 1, and they damage the spinal cord beneath it, then everything listed on this page below thoracic vertebrae 1 will then cease to function, or will have significantly decreased function, and then things above it will continue to function as normal, assuming there are no other injuries or issues. So looking at within the nervous system, so there's 2 major classifications for our functional cells. So we have our neurons, which are responsible for cell-to-cell transmission, and so neurons, and we'll take a look at them as a picture on the next slide. But so we have the soma, which is the body of the neuron, the dendrites, which are branch-like projections from the soma, responsible for receiving information from another neuron. You have the axon, which are long, thin fibers responsible for transmission of information from one neuron to another. We have the terminals, where we actually have the secretion of neurotransmitters. And then all of this, is covered in, so the myelin sheath, which is in essence is insulation for the axon, ensuring faster transmission of information. So you'll notice that wiring, always has some kind of plastic sleeve on it. So it's usually color coded, You'll see there's white, red, green, blue, etc. And in essence, what your body has created that same kind of insulation, or that rubber sheath, but instead we use body fat. And then we have the glial cells, which surround the neurons. And so here you can see, so that previously discussed anatomy on an actual cell model. So again, you have the nucleus inside of the soma, which is the cell body, the long axon, which is where you actually have the myelin sheath, or that fatty covering to increase the speed of transmission, and then the synapse. So remember, the nerve cells don't actually touch. They're very, 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 very close to each other, but then they actually have to send or throw little neurotransmitters to signal to each other. So neurological disorders result from a dysfunction of the neurons, glial cells, or their communication with one another and their target organs. And so again, chemical neurotransmitters are released by one neuron to pass the message to another neuron. And so again, that synapse, is that little space in between, that's the synaptic cleft. So again, in essence, is they're on 2 sides of a river, and then they're basically taking notes, balling them up, and throwing them across to each other, but nothing actually, they're not fully touching. And then similar to insulin, this is using a lock and key model, which is specific neurotransmitters will affect specific synapses. And again, this is why things like certain medications, etc., work, is because they have to be a very, very similar note, So if one person's throwing blue paper across the river, you go, oh, that's not mine, I only pick up the white paper, So if somebody balls up a piece of pink paper and throws it across, and somebody goes, oh, that one's mine, They only respond to a specific neurotransmitter. So here we can see 2 neurons interacting, and I think the most important part to see here is that when you see these branches and these dendrites interacting, is that they are not touching. They're extremely close, but they're not touching, So again, going back to the previous analogy that we used, or synonym, is that in essence it's kind of like there's a river between us, and we're balling up notes of paper and we're throwing them across the river. And again, remembering that people only pick up certain colors. So if I ball up a blue piece of paper and throw it across, only the nerve cell looking for blue paper will pick that up. If it's looking for red, it'll ignore it, So these are specific. So you have a specific neurotransmitter and a specific right, neuron that's going to activate it right when it finds that binding site. So communication within the nervous system. So abnormalities in neurotransmitter production and function have been linked to many neurological disorders. I would make sure, I personally, I would probably put this in my pocket guide. This is kind of the cheat sheet for understanding which neurotransmitter goes with which disease. So here we see acetylcholine is Alzheimer's disease and myasthenia gravis, dopamine in things like Parkinson's disease and schizophrenia, gamma aminobutyric acid in things with like anxiety disorders and Huntington's disease, and glutamate with memory loss and Alzheimer's disease, norepinephrine with bipolar disease, and serotonin with depression. So issues that can complicate nutrition therapy. So severe neurological impairments can compromise mechanisms and cognitive abilities needed for adequate nourishment. So this can affect things like the physical act of eating, so problems swallowing, problems chewing, or a slower rate of intake. It can also affect things like meal planning, shopping, and preparation due to confusion and dementia, poor vision, and poor ambulation or walking. Patients may also have limited access to food or fluid. So you'll notice, right, so usually when you think of and you see in movies, and it is true, is that when people's cognitive abilities decline, is that they're no longer able to operate a motor vehicle. So now they're no longer able to drive themselves to the store, etc. So they're dependent on family, friends, and healthcare providers to drive them to the store. If they're able to get groceries, are they then able to safely prepare those groceries at home? So feeding issues, for actually getting the food from the plate to the patient's mouth, there can be things like limb weakness or paralysis, tremors, spasticity or involuntary movements, poor body positioning, hemiparesis or half paralysis, right, which is weakness on one side of the body, apraxia, so the inability to make purposeful movements. They can have confusion, hemianopsia, which is blindness in half the field of vision. So imagine if you're half blind, again, so similar to the stroke, and neglect, which is just the fancy word for inattention to a weakened or paralyzed side of the body. And so you can imagine, imagine trying to, I don't know if anybody else does this, but I always switch hands when I brush my teeth. So all of a sudden, though, you're no longer able to brush, you're no longer able to switch hands when you're brushing, or you're able to switch hands if you're trying to use something, tie your shoes, etc. And so what happens is that usually that the side of the body that's paralyzed is going to get less attention because it's more difficult to access, right? And that's why occupational therapy will work with the patient to try and counteract some of that, but some of it is inevitable. So here we can see an example of normal vision. You can see the breakfast in front of you. And here we can see hemianopsia. So again, basically we're blind in one eye, in which case, right, we can't even see 3/4 of the breakfast, right? So most of the breakfast is to the left of our field of vision. And you would be surprised that this, combined with some other neurological issues, is that patients will genuinely just forget to eat because they don't notice it. They simply eat what they can see and they move on with their lives. If somebody is sitting there and cueing them and say, hey, don't forget to eat this, or reminds them to actually look at the rest of the plate, they're willing to eat it. But again, when you're missing half your sensory input, it's very easy to just take things at face value and just carry on. You just would eat the English muffin and go about your business. So common diagnoses include things like chewing difficulty, swallowing difficulty, increased energy expenditure, inadequate intake, inadequate oral food and beverage intake, physical inactivity, poor nutrition, quality of life, self-feeding difficulty, underweight, inadequate access to food, or inadequate access to fluid. So we've talked about dysphagia off and on, so this can lead to malnutrition due to poor intake. And again, right, these patients are on this diet because they're at an increased risk of aspiration. And so signs and symptoms, right, of this aspiration or this dysphagia, which could then lead to aspiration, I should say, is things like drooling, choking, or coughing with meals, inability to suck from a straw, which actually requires more coordination than you realize from the muscles in your face, a gurgly voice quality, pocketing food in the cheeks, which is, think hamster cheeks, which is what happens is that, again, you don't realize it, but you actually use your tongue to move food around your mouth and clear it out. And what you'll actually end up with is you'll accidentally keep storing more and more food in your cheeks. So an absent gag reflex. So again, if you've ever had anything, quote unquote, go down the wrong pipe, and then you felt like you were coughing for hours afterwards and you were coughing and coughing and coughing, that's good, right? That's your body actually protecting you from aspiration and getting pneumonia. So it's a very, very strong gag reflex. You will have patients that literally you could pour water straight into their lungs and they wouldn't even blink. And that's because they've had neurological damage, and that's very bad. And so another common symptom, right, is that even if it doesn't become full-on pneumonia, instead you may see these chronic low-grade upper respiratory infections repeatedly. So again, we've talked about, so the speech-language pathologist is going to perform the swallow eval. You should make this person your best friend. So in long-term care and in acute care and in rehab settings, I have always had excellent relationships with speech-language pathologists, but I think it's because I value their opinion so much. But, I can't feed them until they tell me what's safe to feed them. So I want to work with them as much as possible to try and find the right diet that's safe for the patient, that the patient will still accept and eat. So we're going to go through these swallowing phases, but just realize I'm giving you a very brief overview. So for us, what is a couple of slides in one lecture? This is essentially an entire course. So speech-language pathologists do have their master's degree in this, and this is kind of all they do, or this is one aspect of all they do. And so this would be like an entire course. So one of the things you should ideally try and seek out during supervised practice is working with a speech-language pathologist for a day. Realize if they give you more details or they tell you something different than I'm teaching you today, listen to them, not me. Again, they have an entire master's degree in this, and they've taken entire courses on this, on the actual swallowing functions of the face and throat muscles. So listen to them, but this is just a very brief overview. So we'll talk about proper positioning, and so then we'll talk about the oral phase, the pharyngeal phase, and then the esophageal phase. So in the oral phase, food is chewed, combined with saliva and formed into a bolus by the tongue. The tongue pushes the food to the back of the oral cavity by gently squeezing it backwards against the palate, which is just the fancy word for the roof of the mouth. So issues that can occur here is that increased intracranial pressure or intracranial nerve damage can cause poor tongue movement. We can have weakened lip muscles and the inability to use a straw. Patients may be embarrassed by drooling, and so they're choosing not to eat in front of people. And pocketing due to a loss of sensation of the cheek or inability to move the bolus through the mouth, again because the tongue has poor movement. And so here you can see actually moving the bolus or the food actually, right? So the way it actually works is you actually, in essence, slide the food across the roof of your mouth towards the back of your throat. And so that's during this oral phase. This is during the first phase. The second stage is the pharyngeal phase. So this is when the bolus is propelled past the faucial arches. So the soft palate elevates to close off the nasopharynx and prevent oropharyngeal regurgitation, which is a fancy word for just saying, right, is that the flap at the back of your throat closes so the food doesn't go out your nose. Which, right, if you've ever laughed while somebody was eating or drinking milk, right, we know the infamous, right, it will come out your nose. So this is what protects you from that. The hyoid bone and larynx elevate. The vocal cords draw forward to protect the airway. The pharynx contracts while the upper esophageal sphincter relaxes, allowing food to pass into the esophagus. After the food's passed into the esophagus, breathing can resume. So if we have an issue during the second stage, right, then it might be noted that the patient has gagging, choking, or nasopharyngeal regurgitation, right? So the food's coming back out of their nose. Now again, we don't really so much need to know this as that if you see the patient's notes or you see that the speech-language pathologist have written patient gagging will work on second stage, right? They basically have the same way that we would have like rehab exercises, right? If we needed to strengthen our muscles, then patients who need to strengthen, right, their swallowing, there's actually specific exercises that are prescribed for them based on each of these stages. So here we can see as we move into the pharyngeal phase, so again as the food, right, so we see this closure so that things can't go right up into the nose. And then what we're going to see, right, is that the epiglottis is going to close and food's going to pass down the back of the throat into the esophagus. The third stage is the esophageal phase. So the bolus continues through the esophagus into the stomach. So this is the final phase and involuntary. And issues here frequently are going to be things like mechanical obstruction and then possibly neurological disease with impaired peristalsis. So this is something due to, like, for example, damage to the brainstem. But again, these are involuntary muscle movements, so this takes significant damage, right? Normally this is going to still be intact from a neurological standpoint, but you could have a change in the structure, right? So, or mechanical obstruction. And so here you can see, right, the food just continues to be propelled down the esophagus into the stomach. So remember, this is muscle actually pushing the food down into the stomach. Again, I don't recommend it, but right, you can swallow upside down. Astronauts are able to eat food. We do not simply rely on gravity for food to fall down our esophagus, right? It is a muscular tube that actually pushes it down into the stomach. So for patients with a dysphagia diet, so we didn't get to do it in class. We're going to take a look at some of these different food options, but one of the big things is that almost all hospitals can improve their dysphagia diets. When you start changing the texture of foods, right, it has significant impact on the taste and appearance and perception. So things that can help, right, is so aroma. So if it smells good, right, it's going to increase appetite. Improving with the seasoning. So again, we can't just add a bunch of salt because most of these patients are on cardiac diets, but right, patients often have a duller sense of taste, so additional seasoning can help. Garnishing, which again makes things look a little bit better to increase intake. Molding, so we'll take a look at some examples of molding where you actually shape the pureed foods to look more like their original food. Layering and swirling, so you can layer casseroles or swirl vegetables. So you can actually basically, in essence, make like a dysphagia lasagna where it's actually layered the same way and it'll taste the same. Of course, the texture is very different. Piping makes things a little bit better than just a plate of liquid, and then slurries, right, using thickener and juice for milk or breads and desserts. So again, it's like a almost dough-like, but it's again a way for making desserts that are still a little bit thicker. They still have the same sweetness, but they're going to be safer for these dysphagia patients. And so here you can see, so for example, versus, so you have in the center, right, which would be your traditional. So I wouldn't even consider these truly like piped in. They might have been piped in the center, but on the surrounding photos, right, you can actually see instead the way that they are molded. So you can see the corn is pressed into a mold to look corn-shaped. That chicken's not actually a whole chicken breast. That's actually pureed chicken that's been pressed into a mold to look like a chicken breast. You can see the broccoli that's been pressed into a shape, etc., etc. So talking a little bit about the different liquid consistencies, so we know that thin liquids require the most control and coordination. Now liquids can be thickened with dry milk powder, cornstarch, or commercial thickeners. In facilities, we typically use pre-thickened liquids. Again, this is usually due to a legal concern. At home, when you're controlling your own intake, it's much easier for patients to create customized beverages with the right thickener. But as a facility, right, we kind of have to have a consistent policy for all patients, again, from a legal standpoint. So we usually use pre-thickened liquids. They just come in little juice cups and you open them up and they're already at the right consistency. Now this is where we would normally do a taste test. And I can tell you that it tastes completely normal, but the texture throws everyone off. And so usually patients have poor compliance with these thickened liquids, resulting in mild chronic dehydration from decreased fluid intake, which can make patients tired, not feel so great, lead to UTIs, etc. Now some long-term care facilities will allow for drinking water despite the need for thickened liquids. And you'll sometimes hear what's known as the Fraser free water protocol. And so this sounds very strange, but there's always the big concern from speech language pathologists that water will get into the lungs, causing pneumonia. Now, the truth of the matter is that your lungs already have a significant quantity of moisture in them. And so we know that when we breathe out water vapor, so when it's cold out and you can see your breath, right? So there's a significant quantity of water in your lungs. So the problem really isn't water in your lungs, or at least not a little bit of water, but bacteria. And so usually when patients are drinking juice, soda, etc., what's going to happen is you've now created this perfect storm, which is the bottom of the lungs. You've got a nice, warm, dark, damp environment that you've now filled up with a carbohydrate-rich liquid, aka juice, which is the perfect growing medium to grow bacteria in the lungs, and so then they get pneumonia. If, for example, you truly only get small amounts of water in your lungs, you're just going to absorb it, right? Now, again, I'm not saying you can't pour large volumes, right? Of course, that'd be ridiculous. But what we do is what we allow people is basically distilled water. And if you take a tiny sip of distilled water and you and you cough a little bit, and so most of it went into your stomach and a little bit went into your lungs, and it was distilled water without bacteria, you should be okay. Now the problem is that requires a patient who has a much stronger cognitive faculties. They're able to kind of process that information. Hey, this needs to be distilled water, etc., etc. But again, patients do have these rights, so that's the safest way to do it. But then patients can also just refuse and say, I don't care. You know what? I'm totally willing to get the pneumonia, or just give me the antibiotics. I would rather just give me the juice, and I'm going to drink what I want. Now, we advise against that, and we explain to them the side effects and how dangerous this is. But at the end of the day, right, remember, you can refuse any medical treatment. As long as you're of sound mind, you can refuse any medical treatment. So that includes therapeutic diets. So other things to be aware of, so with myelopathy, so it describes any neurological deficit related to the spinal cord, or for example, a spinal cord injury. And so these patients are at risk for neurogenic bladder, urinary retention, UTIs, and then urinary urgency, frequency, or incontinence. And so the reason why this ties into the dysphagia is so what we have is the self-limiting of fluids. And so what happens is so because of these neurological injuries, these patients may be very embarrassed by incontinence, etc. But you can't have an accident if you don't drink any liquid. So then what they'll do is they'll refuse to drink fluids, which of course is very dangerous and very bad for you. So right, again, we kind of have to remove that stigma while then making sure these patients are getting adequate fluid intake. So looking at these textures, so again, as neurological diseases progress, cranial nerves become damaged and it may be more difficult to chew and swallow. So again, you may have a patient who starts on regular food and then slowly becomes, right, mechanical soft and then pureed, right, and having to change their texture. They may need a vitamin and mineral supplement because they're not able to eat the right variety of foods to meet their micronutrient needs. Small, frequent meals, so we'll talk about this with some specific disease states. So what actually happens, right, is that the patient actually gets exhausted early and is not able to finish their meal. Cold temperature foods facilitate swallowing. So again, what happens if you ever had like a nice ice cold beverage on a hot day and you notice that you almost could feel like your muscles like spasming or you could feel like your throat tightening up. We're kind of taking advantage of that where we want these people's throat muscles to tighten up and have the food go into the esophagus and not down into their airway. Sauces and gravies help, again, so we don't choke on, right, if anybody's ever done the 6-cracker challenge, right, we don't want people choking on dry, dusty foods. So moist foods, so avoid anything dry or crumbly, so things like toast. Again, anything that is crumbled, right, is going to need lots of sauces and gravies. And then carbonation can be very irritating as well. So for acute neurological disease, we're going to be using enteral nutrition initially until we determine what degree of function is going to be regained. So again, after a strong rehab program. For chronic neurological disease, we're going to be looking at enteral nutrition to meet long-term needs. And so enteral nutrition is necessary if aspiration risk is high or if the patient is unable to eat adequately orally. We may use nocturnal feeds to allow sensation of hunger during the day. So especially during that acute phase or if we are doing some strong physical rehab with the patient, we may want to do nocturnal feeds and then let the speech therapist work with the patient during the day so they can maximize intake during the day. So again, working on the physical therapy aspect as well as under supervision. And enteral nutrition may be a relief to an overburdened patient, which is, so sometimes it may take a patient so long to eat physically. Again, it is very frustrating to both the patient and family. Again, it may take some of these people 2 hours to eat a meal when enteral nutrition can be done in 15-20 minutes, allowing them to, again, still enjoy time with their families, participate in physical therapy, etc. So we'll talk about our first disease, which is cerebrovascular accident or stroke. And so this is a disruption of brain function due to a sudden blockage or interruption of brain flow of blood flow to the brain, and has neurological deficits lasting longer than 24 hours. So severe strokes are often preceded by TIAs. And so TIAs are transient ischemic attacks or mini strokes. So here we have an episode of ischemia where blood flow is quickly restored and symptoms resolve within 24 hours. So these have no persistent neurological effect. And the other problem with TIAs is that they don't actually show up when we're doing brain scans. So we're really kind of diagnosing them off of symptoms and what the patient describes. But otherwise, we kind of don't know if they've been happening. So unless somebody's observed it or caught it and saw it happening, we don't really know what's going on with the TIAs. So stroke is the third leading cause of death in the US. And so again, looking at what causes it or or what contributes to it. So non-modifiable risk factors include being older. So old age is the most significant risk factor. So the older you get, the more likely you are to have a stroke, as well as gender, ethnicity, and genetics. Modifiable risk factors include hypertension, cardiovascular disease, diabetes, hyperlipidemia, carotid stenosis, cigarette smoking, alcohol use, illicit drug use, poor diet, oral contraceptive use, exercise, and obesity. So let's take a look at the different types of strokes. So we did say that, again, we're looking at an interruption or a blockage of blood flow to the brain. But there are different reasons for that. So we have ischemic strokes, which accounts for 80% of strokes. So here, blood vessels supplying blood to the brain are obstructed. So we have different subcategories within ischemic strokes. So we have embolic strokes, which is a cholesterol plaque becomes dislodged, travels to the brain, and blocks an artery, or a thrombotic stroke, where a cholesterol plaque ruptures within an artery and platelets aggregate to clog an already narrowed artery. Now we also have hemorrhagic strokes, which accounts for the other 20% of strokes, and here the blood vessels in the brain actually rupture. And so we have a subarachnoid hemorrhage, so bleeding into the subarachnoid space of the brain caused by a ruptured brain aneurysm. And so an aneurysm is a dilation and bulging of smooth muscle, usually found at points where cerebral arteries divide or split. And so in essence, what it kind of looks like is it looks like a bubble that's going off the side of an artery that has become thinner and thinner through the epithelial tissue and eventually ruptures. So our pathophysiology, so ischemia, so again we have a lack of blood flow and then a lack of oxygen, which disrupts cellular metabolism to the brain. And so given enough time, we have necrosis of the cells. So without blood supply, right, the cell and oxygen supply, the brain cells will die. So the clinical manifestations, again, the signs and symptoms vary depending on the area of the brain affected. So this goes back to the first few slides when we're taking a look at those cranial nerves and those different lobes of the brain. So depending on where the stroke occurs, we may see loss of vision or speech, paralysis, muscle weakness, change in mental status, or coma. So the medical diagnosis, so hemorrhagic stroke suspected if the patient presents with a headache, decreased consciousness, and vomiting. So we may see, or we will likely see, aphasia, so a loss of speech, or you'll see what's known as word salad, which is they're not saying words that make sense or in sentences that go together. So again, this is going to be confirmed with brain imaging, so we're going to either do CT, MRI, or PET scans, or angiography to actually look at blood flow, or possibly ultrasound. So the treatment you've seen, and so it isn't uncommon, right? So aspirin, warfarin, and other anticoagulants, so depending on if this is a chronic issue with a history of TIAs or if this is a sudden acute issue. And then what's also pretty famous is TPA, or tissue plasminogen activator. So this is a protein produced by the body to dissolve clots. And so we've now created a thrombolytic drug. So we've actually taken what your body would normally produce, but we've now created a concentrated version that we actually can give patients as the quote-unquote clot-busting drug. And so if given within 3 hours of a stroke, patients are more likely to have minimal or no disability 3 months after treatment compared to patients who receive a placebo. So again, we want to restore blood flow to the brain as quickly as possible, and this is how we do it. Now on the flip side, so for example, the next bullet point says the aneurysms will need surgical repair. It's very important that we get patients who have strokes, right? So the mnemonic used for patients is FAST, and so that's where we're going to look at their face, arms, speech, and then time. We need to get these patients to the hospital as quickly as possible to determine what type of stroke. So if somebody is having an ischemic stroke, TPA is a very effective treatment, especially when given early. If somebody is having a hemorrhagic stroke, TPA would be the exact opposite of what you would want to give somebody. But the only way we know that is if we get them to the hospital quickly and can diagnose them, right, and differentiate which type of stroke they're having. So intracranial hemorrhages may need surgical evacuation for large volumes of blood. And again, the big focus with strokes, right, is looking at the rehabilitation period afterwards, which is we need very strong, very intensive rehab to, right, remove or improve the deficits as much as possible. So nutrition implications. So again, we're looking at, so is this a chronic issue? And so once you've had a stroke, you're more likely to have a second one. So what kind of diet will help prevent future strokes? Patient may be comatose immediately following the stroke with impairment of the ability to chew, swallow, or self-feed. Patient may have problems swallowing or hemiparesis with half their body paralyzed, so depending on which lobe of the brain was affected. Patients are at risk for malnutrition, and so again, using those skills that we've looked at with tube feeding, right, we're going to need to individualize nutrition support. So our interventions, so again, it's going to be early nutrition support, modifying the consistency of food, liquids, looking at proper positioning of the patient and swallowing exercises, which will be prescribed by the speech-language pathologist. So assist with feeds, which again can be recommended by the dietitian. So again, if we need a CNA or if they have a specific tech to again assist with feeding, management of the dysphagia, and managing modifiable risk factors going forward. So monitoring and evaluate. So again, that swallowing status and the ability to self-feed. So again, we're going to be closely monitoring SLP notes. Looking at the adequacy of intake. So again, do we need to make that intervention? So if they're not able to eat enough food, do we need to provide enteral nutrition? And looking at weight stability, which is are they losing weight, staying the same, or gaining weight. The next disease we'll take a look at is traumatic brain injuries. So these are classified as either penetrating brain injuries or closed head injuries. So these are due to commonly things like accidents, falls, violence, firearms, sports, etc. So the epidemiology, so 1.4 million TBIs per year in the US, which peak during the ages of 15 to 24 years of age. And so again, if you take a look at men's insurance, so again, insurance for men decreases at age 25. And so again, we take a look at 15 to 24, so we have pro sports, we have military, we have young people who drive like they're invincible and make poor choices, right? We have increased rates of participation in sports. So what you see again is that you see a very specific age range, where again, we have a cluster of these incidences. So 1.1% of the US population live with a long-term disability related to a traumatic brain injury. So falls are the predominant cause, especially in older adults and young children. So again, right, we don't live up north, but if you've ever lived up north and slipped on the ice, you know it's very, very dangerous. So again, what you do then is you see these subcategories. So you see age is most common is 15 to 24, but when it does happen, right, especially when it does happen to adults, it's going to be falls or young children. So again, young children are very clumsy when they're learning to walk. So again, carpets for when they're kids, and then as they get older, switch to tile. So motor vehicle accidents accounts for 20% of traumatic brain injuries. 19% are classified as struck by or against events, such as in sports and recreational activities. Gunshot wounds are at 11%, bicycle accidents at 3%. And then we also have, lacerations, crushing of brain tissue, cerebral edema, hemorrhage, hematoma, infection, and shaken baby syndrome. So you've got a whole bunch of and other causes, right? But you're looking at the major causes are going to be falls, car accidents, getting clonked in the head. So this is going to be your sports, right? So you hit your helmet on something, gunshot wounds, bicycle accidents, and then a very small quantity of and a whole bunch of other stuff. So there are 3 different types of brain injuries. So we have concussion, so a brief loss of consciousness, so less than 6 hours. And again, this is why this has been such a big deal in the media, is that no damage is noted on a CT scan or MRI. So you could have been knocked out for 5 hours. We're gonna wake up, and if we scan your brain, everything looks normal. Obviously, it's not. But that's kind of been the biggest problem and why concussions weren't taken seriously for so long, was when we do the imaging, we don't really see anything. Now we do also have contusions, so we have damaged capillaries and swelling, so the damage will be noted on the CT or MRI, and a large enough contusion can lead to increased intracranial pressure, which is very dangerous. And then we also have what's known as a diffuse axonal injury. So here we have due to the shearing of axons by rotational acceleration of the brain inside the skull. So the damaged area is usually found as the bridge between the 2 hemispheres, which is the corpus callosum. And so what happens is basically you can imagine, so if somebody gets, like a boxer, right, their head is rapidly rotated because they've been hit in the face. And what happens is that in essence your brain basically spins so fast inside your cranium that you actually tear the two halves of the lobes of the brain apart, the left and the right side. And so what's really weird is, so there's actually we can actually do a corpus callosum procedure for patients with epilepsy where we actually shear it on purpose. And it is one of the most unique and unusual medical conditions you'll ever see, because the 2 brains, right, remember we said in the previous slides that the left and the right side talk to each other and they control crisscross. So what happens is when we sever the corpus callosum, what'll happen is if I put something only on the right side of your eye or on the left side of your vision, you'll be able to, for example, you can see it, and then you won't be able to say it because it can't process the information across the now severed bridge. But if we give you pencil and paper, you can write down what your eye is seeing. And then if I switch to the other side, you can say it, but you can't write it down. It is one of the strangest things you will ever see, and that's because of the corpus callosum. We also have subdural hematomas, so blood vessels rupture between the brain and the outermost layer that covers the brain. The epidural hematoma, so again, blood vessels rupture between the outermost layer of brain and the skull, so again, and then intraparenchymal hematomas, so again, blood's pooling in the brain. So these are all the same condition, which is we all have bleeding in the brain with blood, but they're technically in different spaces, so different membrane spaces, so between two different membranes, the membrane and the skull. It doesn't really matter so much to us, so much as more just the side effects. But if you see all of these different words in a past medical history or in a current medical diagnosis, just realize these are all still bleeding in the brain. It's just in specific compartments. So clinical manifestations of traumatic brain injury. So these can vary from the mild to severe depending on the extent and location of the injury. So a mild traumatic brain injury, we may see headaches, lightheadedness, dizziness, blurred vision, fatigue, memory or concentration problems, behavior and mood problems. A moderate TBI, so persistent or worsening headache, seizures, slurred speech, dilated pupils, nausea and vomiting, confusion, agitation, loss of consciousness. And long term, so we may see hemiparesis, changes in speech, movement, emotions, personality shifts, and then possibly even coma or persistent vegetative state. So again, a lot of it's going to be determined based on what happens in the first several days. So again, if the intracranial pressure, so again, if there is bleeding, how severe it is, and again, a lot of this is all going to be determined by the medical treatments. But again, this way you're kind of able to read the patient's current diagnosis and kind of be prepared for what's going to be the long-term plan for enteral nutrition, nutrition support, etc. So traumatic brain injury, so again, as part of the medical diagnosis, they're going to have x-rays and a CT scan. So x-ray is going to look at the skull itself, the CT scan to look at the brain tissue. And so then we have the Glasgow Coma Scale to evaluate and rank the severity of a traumatic brain injury. And so it's a combination of motor response, verbal response, and eye opening on a scale of 3 to 15. And so the most severe level of coma has the lowest score. So in this case, you want a high score. And so here's how you can actually see the scale itself. So for example, eye opening, so spontaneous. So if you walk in the room and somebody opens their eyes and is basically like, oh, wait, what are you doing in my room? That's good, that's 4 points. Again, to verbal stimuli, so if I say, hey, wake up, that's 3 points. If it's pain, that's 2 points. And if they have no response, that's 1 point. Again, so for example, verbal response, are they oriented, or motor response, they're obeying commands. So if I say, hey, can you pick up your left arm for me, or can you take a sip of water, right, and you move your arm perfectly, that's good, right? If you only withdraw in response to pain, that's bad, right? And so you can see again, so based on this score, you get based on this scale, you get a score. So again, 8 or less is severe, 9 to 12 is moderate, and then mild is going to be 13 to 15. So the medical treatment, so acute treatment focuses on stabilization, so maintaining blood flow and oxygenation to the brain while preventing shock, preventing any further complications, and promoting rehabilitation. So nutrition therapy, again, we said is going to be an integral part of the team. So again, especially if we're going to be looking at nutrition support. And so again, surgery for removal or repair of hematomas and contusions. So again, you may have to incorporate that into your planning, right, your injury factor, right, depending on the extent of the surgery or if it's a single or multiple surgeries. So we may see in these patients hypermetabolism, hypercatabolism, so an increased breakdown of muscle mass, hyperglycemia, insulin resistance, increased gluconeogenesis, and lipolysis, and so catabolism as evidenced by nitrogen excretion. And so research has shown that nitrogen balance is not reached until week 3 in these patients. So again, similar to that trauma and stress patient that we looked at in the previous chapters, where again, you're going to have that significant catabolic response with inflammation and breakdown of tissue. So intervention requires aggressive nutrition support with timely enteral or parenteral nutrition to minimize catabolism of body lipids and protein, as well as decreasing the inflammatory response. So again, we'd like to start within the first 72 hours. Energy needs can be highly variable with somewhere between 1 to 1.4 for your injury factor. So sedatives, though, may reduce metabolic rate. So again, we've got to, again, it's that kind of that art of what to provide the patients. Protein at 1.5 to 2.0 grams per kilogram per day. So again, similar to our burn patients, giving them more and more and more doesn't help. And then monitoring and evaluate. So again, looking at nutrition care, right, and how it needs to be modified, looking at those transitional feeds to get back to oral intake as soon as appropriate. And so current research is looking at pyrazole, so a derivative of curcumin, so looking at reestablishing membrane integrity and homeostasis following a traumatic brain injury. So we know that curcumin, right, is an anti-inflammatory, right, and this is a constituent of turmeric and has antioxidant properties as well. And omega-3s, so DHA and EPA, can help with neuron protection in the damaged brain. So again, anti-inflammatory, antioxidant, and anti-apoptosis effects. So again, omega-3s are going to definitely be beneficial as long as we don't overdo it. All right, so we'll move on to spinal cord injuries, which we've alluded to a little bit previously when we were talking about the anatomy of the spinal cord. So we kind of implied or talked about how this would affect, right, damage to the spinal cord would affect the function of the organs and tissues below it. So a spinal cord injury, so we have injury to the spinal cord involving fracture or compression of the vertebrae with consequent damage to the nerve cells. So remember, your spinal column, right, are bones, and then they have a hollow tube, and then within that tube is your spinal cord. Now these can be a complete or partial injury. So a complete injury indicates no function below the point of the spinal cord injury and can result in paraplegia or quadriplegia. And a partial injury indicates the individual can experience sensation and may have voluntary movement, but they may have numbness, tingling, or weakness depending on the compression, how long the spinal cord was compressed or damaged, etc. So epidemiology, so there are approximately 12,000 new cases of spinal cord injury per year in the US. So most is due to trauma and accidents, with a small percentage being from tumors, spina bifida, multiple sclerosis, or infectious disease causing damage to the spinal cord. So there are two types. So we have tetraplegia, or what used to be referred to as quadriplegia, so infecting all four limbs, and paraplegia, so again affecting only the lower extremities. So again, the pathophysiology, so the level of injury determines the signs and symptoms. So again, it depends on, we said, which nerves are severed. So you have the cervical spine, thoracic spine, lumbar, and sacral. And so complications from paralysis may include pain, breathing difficulty, spasticity, thrombosis, embolism, or syrinx, which is a fluid collection in the center of the spinal cord, which puts pressure on the spinal cord. This is not good. So the medical treatment, right, is to treat the underlying cause. And so again, right, this is why you see like the things like halo or again spinal fusion. So again, you would treat the actual damage to the structure, corticosteroids to treat the inflammation, again stabilization of the patient, and then on rehab. So again, depending on if the spinal cord is compressed versus severed, these may have initially they'll have the same symptoms, and again, we won't know a lot until the inflammation is gone to see if the damage to the spinal cord is permanent, or again, because there was just pressure on the nerve, right, with reduced pressure and inflammation, we may actually regain some function. So again, we won't know, like I said, usually until we see the inflammation subside. So nutritional implications. So decreased energy expenditure and caloric needs due to a lower level of spontaneous physical activity. That's a nice big fancy word of the fact that you'll notice as you're probably even watching this lecture, you might be tapping your foot. But obviously, right, if we have paralysis from the waist down, people don't tap their feet. The same way, right, that we would just engage with nervous movement, nervous tapping, shifting, shuffling, right, all of those motions are no longer present. So we actually have a decreased metabolic rate from decreased activity. Over time, there will be a loss of muscle tone due to paralysis, so the muscles will actually atrophy. Now, there is actually physical therapy to help delay this and help prevent some of this, but it is inevitable, right? We're going to have some atrophy of, right, the denervated or loss of nerve, right, sensation tissue, because there's no longer a signal for it to flex and maintain its muscle mass. Reduced metabolic activity from the denervated muscle, so again, that muscular atrophy. So energy needs are approximately 10% less than predicted needs. So we would do the MSJ and then multiply that by 0.9, for example, to decrease it by 10%. So patients with spinal cord injury are at increased risk for obesity, cardiovascular disease, atherogenesis, pressure ulcers, constipation, and UTIs. So our interventions, so energy requirements via indirect calorimetry would be ideal, but we do have some different equations based on some research. So we're recommending 22.7 calories per kilogram for quadriplegic patients or tetraplegic patients, and 27.9 calories per kilogram for paraplegic patients. Protein, we recommend 2 grams per kilogram in the acute phase. So again, while we're trying to heal tissue, and we have that traumatic event where we have that hypercatabolism and breakdown of tissue. But then in the rehab setting, right, once the inflammation has subsided, approximately 0.8 to 1 grams per kilogram is adequate. Higher calorie and protein needs if there are pressure ulcers. So again, because the patients are in one position for so long, it is prominent for them to get pressure ulcers or bed sores. So again, if they do have that tissue breakdown, we want to ensure that we're giving adequate calories and protein to support healing. Early nutrition support is linked with better outcomes. And again, a big focus on adequate fluid at more than 1.5 liters per day and adequate fiber at more than 15 grams per day. So again, we want to look at bowel and bladder function. Again, the biggest issue is with incontinence, right? There is a tendency to self-restrict fluids. But again, we do want to make sure that we're having adequate fluid and fiber intake. We want to prevent excessive weight gain and fish oil supplementation. Again, that focus on cardiovascular health and inflammation, and again, with very little negative side effects. Monitor and evaluation. Again, so prevention and healing of pressure ulcers is going to be our long-term strategy. And again, weight management, along with that weight management will come the cardiovascular disease management. So we'll move into our next set of diseases or disease, which is epilepsy and seizure disorders. So epilepsy, so a disorder characterized by spontaneous, uncontrolled electrical activity among cerebral neurons resulting in what we call a seizure. And so a seizure or convulsion can occur in a portion of the brain or the entire brain. And more than 2.3 million Americans have epilepsy. And so 45,000 children under the age of 15 will develop epilepsy each year, approximately 1% worldwide. And so 10% though of the population will have a seizure in their lifetime. So please understand there is a difference in epilepsy, which is a disorder with repeated seizures, and a single seizure. So that's why you'll see how can these numbers be so different. So it is possible you'll have one seizure and then never have it again, depending on what caused it. So etiology, so commonly caused by an insult to the brain, such as head trauma, central nervous system infections, drug and alcohol abuse, tumors, and cerebrovascular disease. However, majority of patients with epilepsy have no precipitating event. So again, as we see, you can just have a one-off, a single-time event seizure. Again, so from excessive alcohol intake, from having alongside a stroke, from having a head trauma, but that would be the only one you have. That doesn't mean you have epilepsy, right? So epilepsy, there's usually no precipitating events, and then we have these recurrent seizures. So seizures can range from a few seconds long to over 5 minutes. And so what we have, so if we have severe seizures, right, we have status epilepticus, which can require heavy medication and sedation. So again, just don't forget to differentiate between a single seizure and a diagnosis or a history of epilepsy. And again, I think it is definitely very difficult to watch, and it's very unnerving. But again, this is from the current research we have available, right, is that seizures less than 5 minutes aren't considered severe. Now, again, you try and tell that to the people that had to watch the patient go through that, and they might disagree. But again, from what we've seen from the research, right, if it's less than 5 minutes, it's on the less severe side. So our generalized seizures involve the entire brain. And so we have the tonic-clonic seizure, which is characterized by a mixture of symptoms. But this is what we used to call a grand mal seizure. But when you're thinking of a seizure in your head, like what you think of in the movies, where people are having, they're clenching their jaw, when you see the foaming at the mouth, when you see somebody with the spasticity movement, right, and they're on the ground, that's a tonic-clonic seizure. So an absence seizure, so a person appears to be staring without response, previously referred to as a petit mal seizure. And so again, basically, it's imagine like an extremely severe and obviously dangerous form of daydreaming, where they're basically just staring off into space and just locked. In which case, and then the brain is just kind of figuring out what's going on. There's kind of some electrical activity as things are short-circuiting, and then they'll snap out of it. So partial seizures involve one part or lobe of the brain, and so a simple partial, so the patient's aware of the event and can recall what happened, and a complex partial, so the patient's unaware of the event, is confused and tired afterwards. And so the symptoms, right, from the seizure vary based on the area of the brain affected, and that's why, so for example, the entire brain ones, right, have the much more generalized symptoms that you think of, whereas if it's partial or only one part of the brain, then it may be a very specific symptom. So medical diagnosis, so we do an electroencephalogram or EEG to record electrical activity of the brain. And so then we just record this video over time, and so we can see again that change in electrical activity, which then corresponds to symptoms in the patient. And so the medical treatment, so what we've now moved on to is pretty much our first line treatment is our anti-epileptic drugs, or AEDs. So these are things like Dilantin, phenytoin, phenobarbital, Tegretol, and Keppra. And these basically are sedatives. It's a little more, it's technically not a sedative, but what it does is it calms some of the electrical activity in the brain to reduce the risk of those seizures. Now we do have surgical treatments if meds don't work, so we have vagus nerve stimulation, lobectomy, hemispherectomy, and corpus callostomy, so we can sever the two halves of the brain, we can remove a hemisphere of the brain, we can remove specific lobes of the brain. But again, depending on if it's a seizure in a specific spot, if it's a generalized seizure, right, then we have different options. And then, of course, what probably most people are familiar with because of this field is the ketogenic diet. So the true ketogenic diet, so a high-fat, adequate protein, low-carbohydrate diet, so designed to create and maintain ketosis. And so remember, we're looking at nutritional ketosis, which is an increase in ketone bodies in the serum and urine, so again, caused by severely restricting carbohydrates. So glycogen stores in the liver and skeletal muscle are depleted, and the body is forced to break down fat stores for energy, producing ketones. So this was a popular treatment in the 20s and 30s, but was abandoned with the invention of anticonvulsant drugs. So once we basically invented phenobarbital, again, we got such good results that they kind of stopped the research on the ketogenic diet. But 20 to 30% of cases fail to control seizures with medication. So again, the medication doesn't work for everyone. We looked at surgical options, but there is also the ketogenic diet as an option. And so a meta-analysis of almost 1,100 patients reported seizures reduced by 90% in a third and by 50% in half the patients with the ketogenic diet. So again, there's very little side effects, so it's worth trying. So we don't know the exact mechanism for why the ketogenic diet works. We have a theory. And so what we know is that the brain tissue prefers to use glucose, right? We've said this repeatedly. And so what happens is when we place somebody on a ketogenic diet, we are depriving the brain of such large quantities of glucose. Now, the reason why this is important is that glucose uptake increases or accelerates during seizures. So it's possible that the reduced availability of glucose during this ketosis translates to a lack of glucose for the ability for the neuronal membrane excitability, right, or that sudden uptake by the brain cells. So your brain likes glucose, and when you have a seizure, which is basically a thunderstorm in your brain with all the lightning, it sucks up all the glucose. And instead, we don't give your body glucose. So then there's no glucose for your brain to suck up and cause the thunderstorm. And so that's our current working theory for why the ketogenic diet reduces seizures. So the classic ketogenic diet, so this is the most widely used and requires strict adherence. So this is a high-fat regimen. So again, this is not the Atkins diet, right? Here what we're looking at is truly, right, a true ketogenic diet, which is high-fat and adequate protein. So we typically prescribe approximately a 4-to-1 ratio, so 4 grams of fat for every 1 gram of protein and carbohydrate. And calories are calculated about 80 to 90% of RDAs, with about 80% of the total calories coming from fat. And again, so the minimum amount of protein to promote growth and development, so 1 gram per kilogram. We don't want to go excessively high on protein, as we know that protein can be used in gluconeogenesis to create glucose. That is mostly theoretical. We have not actually observed that, but we are concerned about gluconeogenesis and increasing glucose by excessive protein intake. And then small portions of carbohydrates to make up the remaining calories. And we should be careful, right, of looking at for contaminated sources. So toothpaste, soaps, lotions, vitamins, etc., that may all have a cumulative effect, right, and be high in carbohydrates. So children's vitamins, right, contain sugar to make them more palatable, right? So soaps, lotions, right? So you'll see all these honey soaps, things like that, that may actually have some small amounts of glucose that on their own really aren't that bad. But if all of a sudden we start taking into account, they start adding up, right, and we're looking at several, right, multiple grams of glucose, again, if we're truly to get the maximum therapeutic effect, we just have to be careful. And so here you can see a sample, so ketogenic diet meal. So this is for a 5-year-old with a 1,200 calorie diet, 19 grams of protein per day. And so this is 4 meals. So for example, breakfast is going to be bacon and eggs with a small quantity of strawberries, a little bit of canola oil and cream. Meal 2 is going to be, again, that canola oil and cream. So again, we're going to get our essential fatty acids, our omega-6s. And then we have basically your classic Cobb salad. So we've got lettuce, grilled chicken breast, ranch dressing. Meal 3 is going to, again, be, so again, higher fat, so that cream and canola oil. And then we have, again, our spaghetti substitutes. We're going to have spaghetti squash with cheese and butter. And then meal 4 is going to be, so here we have a version of a chicken salad that's going to be low in carbs. So red grapes for a little bit of carbs, but the rest of it's going to be so dill pickles, shredded chicken breast, and then making sure that it's low carb or true mayonnaise, which shouldn't have any carbs in it. Again, store-bought being the ones that are going to be higher in sugar. And so again, we have a pretty traditional, right, very low carb, higher fat, lower quantity protein, true ketogenic diet. So most experts agree the diet's worth trying when 2 or more medications have failed to control seizures. So requires medical guidance and supervision. And so we may want to try this with a patient in the hospital before they go home. Again, especially if they're transitioning off of meds and using the diet instead. So if the diet's working, right, then most doctors will prescribe it for 2 years and then slowly begin weaning. And so possible side effects, though, so constipation, low bone mineral density, pancreatitis, dehydration, kidney stones, or gallstones. So again, the thing is, right, being on this as a child, right, lifelong is a little different than being on an adult, right? You're looking at much higher quantity intakes, which just stresses the system a little bit more. And so about 1/3 of children who try the diet become seizure-free, 1/3 improve but still have some seizures, and then 1/3 are non-responders or show no improvement. And this is pretty standard, right, for any medication or medical intervention. It doesn't work for everyone. It works for a lot of people, but not everyone. So our nutrition implications, so again, inadequate nutrient intake. So again, we want to focus on adequate energy intake. So again, ketogenic diet, we're making sure we're getting total calories, and then also making sure, right, that depending on the severity of the seizures, they're actually able to eat enough nutrition. There's limited choices on a ketogenic diet, so it's low in fiber, calcium, and other nutrients that need to be supplemented, and growth may be slowed, which is the big reason for transitioning children off of it, is making sure they're getting adequate calories and reaching their maximum growth potential. And again, possible drug-nutrient interactions. So again, so our nutrition interventions for epilepsy and seizure disorders. So again, a ketogenic diet with a carbohydrate-free multivitamin with minerals. So again, just be aware, the biggest offender of this is things like the Flintstone vitamins, which do contain sugar. Adequate energy, protein, vitamin, and mineral intakes is our focus. And drug-nutrient interactions, so again, the potential for weight gain or loss. Avoiding grapefruit juice with Tegretol. Dilantin can interfere with vitamin D and folate metabolism, and dilantin and phenobarbital are bound to albumin, so if serum albumin is decreased, then there will be increased free drug concentration, putting the patient at risk for drug toxicity. Similar to our previous discussion on metabolic stress, so dilantin will bind with tube feeding, so if the patient is on dilantin as well as a tube feed, then again, the tube feed needs to be held 1 hour before and 1 hour after they receive the dose of dilantin. And phenobarbital should be given around food/meals due to the absorption of the drug being delayed by food. And so again, the biggest thing is that we want a slight delay, right? We don't want somebody to get a sudden rush of the medication and in essence become excessively drowsy. So things that we can monitor for patients on these types of diets. So the beta hydroxybutyrate, or BHB, is a blood ketone that's monitored as a ketosis marker. So this is kind of like, instead of checking blood sugar, we check blood ketones. standard lab panels, and then being on the lookout for vitamin and mineral deficiencies, nutrition status, and proper growth, and again, keeping seizure frequency records to see if this had the effect that we were desiring. So migraine syndrome, so an episodic intense throbbing pain that lasts for 4 to 72 hours. This may be accompanied by nausea, vomiting, and visual disturbances such as seeing flashing lights or blind spots, and sensitivity to extreme light and sound. More common in women ages 15 to 55, and the current cause for migraines is unknown, but it seems that genetics and environmental factors play a likely role. So possible triggers for migraine headaches, and so again, this is a very expansive list, but hormonal changes in women, age, salty processed foods, food additives such as MSG and aspartame, alcohol or caffeinated beverages, stress, sensory stimuli including bright lights, sun, loud sounds, or unusual smells including perfume, paint thinner, and secondhand smoke, changes in sleep patterns, changes in environment including barometric pressure, and medications such as oral contraceptives and vasodilators. So the treatments, and so pain relievers and NSAIDs, so this is your things like, you'll see the Excedrin migraine, triptans, which promote constriction of blood vessels like Imitrex, and so what you'll notice is that this is why your pain relieving NSAIDs will usually contain caffeine when they're targeting the migraine population, so again a similar effect but much less significant compared to the triptans, and anti-seizure drugs such as anti-seizure drugs, Botox, and antidepressants depending on the source of the migraines. From a nutrition standpoint, we want to avoid the trigger foods. So again, these are going to be determined by each individual. Tyramine and phenylethylamine may trigger. Dehydration may trigger. Coenzyme Q10 and riboflavin may help prevent or mitigate symptoms. And magnesium has been shown to be effective in mitigating or making it less severe. All right, so we'll now move into progressive neurological disorders. So we have our neurodegenerative disorders, in which the medical management can be challenging, and nutrition needs and status may be affected by the progression of the disease. We're going to usually have to make ethical decisions or speak with the family about ethical decisions regarding nutrition support. But the nutrition therapy is pretty similar among progressive disorders, so they have similar implications long term, with poor appetite and intake and swallowing and chewing complications long term. So the diseases we'll take a look at include Parkinson's disease, amyotrophic lateral sclerosis, or ALS, Guillain-Barré syndrome, or GBS, myasthenia gravis, multiple sclerosis, Alzheimer's disease, and dementia. So Parkinson's disease, so a neuromuscular neurodegenerative disease caused by a loss of dopamine-producing cells. So first described in 1817 by James Parkinson as shaking palsy. And so it is one of the most common neurodegenerative diseases affecting 1% of the population over the age of 65. 66% of patients are disabled within 5 years, and 80% are disabled within 10 years of a diagnosis. And Parkinson's disease is more common in men. So the direct cause, so again, we know it's from a loss of dopamine, but we don't know is why did someone lose dopamine-producing cells. So that part's still unclear, but we do have some proposed contributing factors. So these factors include genetics linked to chromosome 4, exposure to environmental toxins, protein malformations, oxidative stress, imbalance of neurotransmitters, mitochondrial dysfunction. Again, we see the loss of the ability to reproduce dopamine-producing cells, so why can't we replace the ones that are malfunctioning? Abnormal inflammatory response within cells of the brain, and increased rate of cell death. So again, our pathophysiology, we see a progressive loss of dopamine with an imbalance between excitatory dopamine and inhibitory GABA, which are two neurotransmitters. So clinical manifestations include a resting tremor, rigidity, bradykinesia or slowed movement, or akinesia, a loss of movement, along with a stooped posture, shuffling gait, and cognitive dysfunction. So the medical diagnosis of Parkinson's disease, the diagnosis is difficult as there's no definitive test. So we evaluate for the presence of symptoms and response to treatment in order to make a diagnosis. So a useful acronym is TRAP, which is tremors, rigidity, akinesia, and postural instability. More than 10 genes have been identified causing familial Parkinson's disease, but genetic testing is not done routinely at this time. So the medical treatment, which I'm wondering, I'm sure so many of you probably already reached, is that if it's a loss of dopamine-producing cells, why don't we just give them dopamine? And it's kind of what we do. So this is primarily treated with levodopa or L-dopa, which is actually the precursor for dopamine to compensate for the diminished availability. So instead what we do is we actually give them the precursor, and then the body itself will convert it to dopamine. If we were to give you the dopamine itself, it would probably be damaged too severely by the digestive tract to have any real function. We also use decarboxylase inhibitors, which reduce the breakdown of L-dopa. So this is the drug carbidopa. We have dopamine agonists, which bind to and activate dopamine receptors in the absence of dopamine. So in essence, it's synthetic or fake dopamine. So we have things like Requip and Mirapex. Cholinesterase inhibitors stop the neurotransmitter acetylcholine from breaking down. And so acetylcholine is involved in memory and thinking. So this is an adjuvant therapy. This is not the dopamine itself. And then we have combination medications where if you're going, hey, all of those sounded like good ideas, well, we do make those, right? So we have make combination medications like Sinemet, which combine L-dopa and carbidopa to get the maximum potential. So nutrient implications and diagnoses. So drug-nutrient interactions, again, are of important concern. So we were worried about weight loss in the patients, poor intake, dehydration, decrease in self-feeding. So again, especially as the tremors worsen, it can be more difficult to self-feed. Chewing and swallowing difficulty, overweight and obesity, and the impaired ability to prepare food and meals. So things to focus on. So a high protein diet may interfere with L-dopa levels. So L-dopa is transported by the same protein carriers that transport amino acids, so they compete. So evidence indicates that results aren't consistent in every patient, but we recommend avoid taking the L-dopa with high protein foods. Again, it's not going to hurt, but it may provide benefit. Fiber and fluids to prevent constipation, omega-3s and vitamin D, again looking at inflammatory processes, and other anti-inflammatory compounds such as resveratrol, curcumin, apocynin, and epigallocatechins are being explored. So we want to limit the supplement levels of B6 to 15 milligrams per day. So B6 is a required cofactor for dopa carboxylase, which is one of the enzymes needed for the conversion of L-dopa to dopamine. So supplements high in B6 may expedite this conversion before L-dopa reaches the brain, thereby reducing the amount of dopamine actually transported to the brain. So it'll actually go through the cycle too quickly. Again, monitoring weight status, and then GI symptoms. Again, so we talked about to prevent constipation, we were looking at fluid and fiber, and an altered food texture and liquid consistencies may be necessary. So we'll move to our second neurodegenerative disorder. We'll take a look at amyotrophic lateral sclerosis, or ALS. So a progressive neurological disease that affects the motor neurons of the nervous system. And so these are the motor neurons that control voluntary movements in the body. And so this is also known as Lou Gehrig's disease. Now the good news is that this disease is incredibly rare, as it's quite nasty, it's quite awful. So it's 2 to 3 cases per 100,000 individuals. Slightly more prevalent in men, and average age of onset is the mid-50s. So cause is generally unknown except in the cases of familial ALS. And what we do see is that elevated homocysteine levels are known to damage motor neurons. Remember, that's also a risk factor with cardiovascular disease. And again, so homocysteine, we know high levels have negative consequences in the body. So the pathophysiology, so destruction of neurons involved in controlling the stimulation of muscles. And so the cellular response to injury can involve replacement of normal cells with non-functional cells. So dead neurons are replaced with non-functional fibrous cells. So the muscles atrophy due to the inability of neurons to stimulate muscle action. Now we do have bulbar and spinal forms, so depending on where the neuron deterioration begins, it doesn't play so much of a role in nutrition care, but just if you do see in the physician's notes, if they note something like that, basically they're just variant forms of the same disease. But again, from a nutrition standpoint, we're going to treat it pretty much the same. So clinical manifestations, so asymmetric muscle weakness and atrophy, hyperreflexia or hyperstiffening of the muscles, and fasciculations, which is uncontrolled twitching. So extensive muscle atrophy leads to paralysis, a need for mechanical ventilation, difficulty swallowing, and the need for nutrition support. So again, this will lead to a PEG tube. And again, so we get to the most horrifying part of this disease, which is mental acuity is maintained. So again, we typically think of with degenerative disorders is that, at least they're not suffering or they're not aware. And unfortunately with ALS is they are completely aware, right? So there's not been any damage to the brain. It's actually to the rest of the motor neurons. So the brain is trapped and can't actually communicate with the rest of the body. So it's definitely a scary illness. So a high risk of aspiration, pneumonia, and then eventually leading to sepsis. So medical diagnosis, so complete neurological exam to rule out other diseases. Again, no single diagnostic test exists. So the medical treatment, so again, no cure. This is a very poor prognosis with a progression to death in 2 to 6 years. Now we do have the medication Rulazole, which is the first FDA-approved drug for ALS, which appears to affect the release of the neurotransmitter glutamate. So the mechanism is not known, but it may extend life for 2 to 3 months. Again, we're looking at a lot of symptom control, so looking at excess of saliva, pain, depression, and again, a multidisciplinary team approach. So you're going to have the neurologist, you're going to have the speech therapist, the dietitian, etc. Right? So again, determining what's going to be the best plan of treatment for this patient. Other things to be aware of, so high doses of B12 to lower homocysteine levels. So again, these patients may be hypermetabolic and have increased needs. So despite the fact they'd have decreased movement, they may actually have increased needs. Again, the dysphagia, so an altered food texture and liquid consistency may be appropriate. And nutrition support, again, a PEG placement if aggressive therapies are desired. So the Perelman School of Medicine from the University of Pennsylvania Health System so had they basically a position, a stance, and some statements about this. So ALS patients who have feeding tubes placed before an emergency situation strikes will do better. The median survival after the feeding tube surgery was 6 months overall, and median survival was longer for patients undergoing non-emergent versus emergent tube placement. So again, you saw the median, but again, almost doubling the time. So if we waited till there was an emergency, it was only 4 months, but if we placed this prophylactically or ahead of time, we had 7 months of survival after placement. So Guillain-Barré syndrome, or GBS, so an acute peripheral nervous system disease characterized by progressive paralysis, so a rapid onset. And so this is the absolute freakiest thing, which is can eventually resolve completely or leaving lasting impairment that could result in death. But typically, given enough time, it actually will reverse. Now, there will be some side effects and physical therapy afterwards, but in essence, when you first get it, Guillain-Barré looks just like ALS. And then one day, poof, it starts to go away. It's pretty wild. Like the neurological diseases are just something else. So epidemiology, again, incredibly rare at 1 to 2 cases per 100,000. It is more common in men. But here's the real kicker. So this is probably one of the only things that's ever made me consider going vegan. So shout out to Thais. So the etiology is not completely understood, and there may be an autoimmune response to an infectious trigger, but 60% and possibly more cases are preceded by an infection, specifically Campylobacter jejuni, which is most famous, right, for bad chicken. So more than half of people who have this disease basically had contaminated chicken beforehand, which is just crazy. So onset occurs anywhere from a few hours to 3 to 4 weeks after infection. So autoantibodies attack specific cells of the nervous system and cause damage to the myelin sheath, axons, sensory nerves, and nerve roots. So nerve demyelination causes neuropathy and a loss of function in affected nerves. And so symptoms normally peak by 2 weeks, but may progress for up to a month. So the patient develops areflexia, or a loss of reflexes, and rapidly progressive paralysis involving all limbs. So it starts with numbness or tingling with paresthesia and progresses to muscular weakness and eventual paralysis, and in severe cases, dysphagia and respiratory failure. And so what happens is basically these patients get numbness and tingling in their feet, and it slowly crawls up their legs, and it crawls up their torso. And what will happen is depending on how quickly it's crawling and how quickly right? So it says it peaked at 2 weeks. And so literally what we do is we just kind of put you in the hospital once we figure out what it is, and we just watch you. And there's nothing we can do about it. We just watch and provide supportive care. And so if the paralysis goes high enough up to paralyze your diaphragm, we have to give you a breathing machine. If it doesn't go high enough up, we don't. If it goes high enough up, you may have swallowing difficulties, etc. And then after 2 weeks to a month, like a tide rolling out, it slowly starts to get better and improve. And so it just kind of, now again, these patients usually need significant physical therapy. They have to learn how to walk. But again, you went from being completely paralyzed and on a machine to then you can just see like a tide, right? The tide rolls out and you can see the paralysis slowly recede back down the body, sensation returns, and then the patient goes to physical therapy. It's one of the craziest things you'll ever see. So medical diagnosis, so we do a medical history and looking for any bouts of recent illness. So a nerve conduction velocity test to determine if nerve signaling is impaired. And a spinal tap to assess protein content in spinal fluid. So GBS patients will typically have high protein levels in cerebrospinal fluid. So the treatment is high-dose IV immunoglobulin, or it's an antibody produced by B lymphocytes, and plasmapheresis to remove antibodies from plasma to stop you from attacking yourself. And so 85% of patients with GBS will completely recover in a year and a half. So, right, for basically 2 weeks to a month, you're completely paralyzed, you're on a breathing machine, possibly a feeding tube, and a year and a half, you go to physical therapy, and it's almost like it never happened. I mean, neurology is some wild stuff once you see these patients. So our calculating nutrition needs, indirect calorimetry would be ideal. So energy needs may be as high as 40 to 45 calories per kilogram. Protein needs may again be at that 2 grams per kilogram. If the patient has dysphagia, may need altered food texture and liquid consistency, so this may be during or then immediately after, right, the acute attack. And food safety, right, to prevent future infection. Again, I'd probably be switching to tofu, but improperly prepared meat and poultry, the most common causes of Campylobacter jejuni. Like I said, if I had it, I'd probably be switching to tofu. So now we'll talk about myasthenia gravis. So spoiler alert, because I think the final season just finished airing, but some of you might watch a TV show known as Empire. And the only reason I bring this up is so spoiler alert, at the end of the first season, it turns out he doesn't have ALS, dun dun dun, which is the whole plot device is that he has ALS and he's going to lose his empire. The end of the first season, it turns out he has myasthenia gravis. And so you'll see why they have some similar symptoms, but again, why that makes such a significant difference in the show. So this is an autoimmune progressive neuromuscular disorder affecting skeletal muscles. So it results in varying levels of muscle weakness and fatigue. So epidemiology, 1 in 7,500 individuals, so much more common than ALS or GBS. So etiology, so again, exact cause is unknown, but it appears to be an autoimmune reaction that destroys the cellular receptors for acetylcholine, which is in 85% of cases, and then an abnormal thymus gland or tumor in the remaining 10 to 15% of cases. So pathophysiology, so reduced number of acetylcholine receptors causes muscles to tire easily and causing muscle weakness. So muscle weakness is exacerbated by physical activity. I know what you're thinking, which doesn't everybody get exhausted from physical activity, but this is to a more extreme degree. Most commonly affected muscles are of the face, eyes, arms, and legs. And we also see dysphagia with fatigue following mastication, i.e., we see problems swallowing and severe tiredness after chewing our food. And then the key, right, so again, if you were following Empire, so drooping eyelids and dysplopia, which is double vision. So in essence, the muscles controlling your eyes get so exhausted they can't focus, and you get double vision. And this is significantly different than ALS, which is that long-term paralysis and poor nerve signaling, which again is the spoiler alert. So we have periods of remission and exacerbation, so it gets worse, it gets better. So for the medical diagnosis, we have a tensilon test. So we inject the drug tensilon that acts by allowing acetylcholine to accumulate in the muscle, resulting in improved muscle function. We also have the repeated nerve stimulation test, so measures response of a single nerve to a series of electrical stimulations. And so we can assess for anti-AChR receptors. So again, a positive test, again, indicates that you have those antibodies. So again, in essence, right, you're attacking yourself, and this is confirming, right, a diagnosis of myasthenia gravis. So unfortunately, right, with autoimmune diseases, there is no cure, but we do have some effective treatments. So we have anticholinesterase drugs, immunosuppressants, which we use consistently with all autoimmune disorders, IV immunoglobulin. Now, if it is one of those 10 to 15% of those rare cases, we have removal of the thymus gland or a thymectomy as an option. And then again, plasmapheresis so again, we're basically filtering your blood through fancy coffee filters to remove those antibodies that would be attacking your body. So if there's dysphagia, we may need an altered food texture and liquid consistency. So again, if the patient's tiring easily, small frequent meals or things that are chopped up to make things easier, so we chop it up ahead of time. Again, nutrient dense, it's easy to chew. Limiting physical activity prior to mealtime. Possibly an NG tube for temporary nutrition support if there's a flare-up. And if the patient's on a breathing machine, then we may need a swallow eval once they're off the breathing machine or extubated to assess the degree of deglutitory dysfunction and risk of aspiration. That is a really fancy word for saying that after you have a tube stuck down your throat, it's harder to swallow. So we have to do a swallow test after we pull the tube out of your throat. So now we'll move into multiple sclerosis. So multiple sclerosis, an autoimmune disease characterized by destruction of the myelin sheath within the cells of the central nervous system. It's with the development of scar tissue, right? So that sclerosis or that hardening of that tissue to replace the destroyed myelin sheath. So this results in distortion or interruption of nerve impulses causing numbness or tingling in the limbs, loss of coordination, weakness, paralysis, and loss of vision. So approximately 400,000 individuals in the US, or approximately 2.5 million people worldwide. So it is more common in women and is usually diagnosed between the ages of 20 and 50 years of age. So the etiology, so the exact cause is unknown, but it does seem to have a genetic autoimmune component or exposure to infectious agents. So chromosome 6 appears to be highly linked to multiple sclerosis. Vitamin D may inhibit multiple sclerosis progression. So increased degree of sunlight exposure linked to decreased MS. So there's a study. So that's the Mark and Carson 2006. The risk of getting MS was 1.6 times greater for current smokers and 1.2 times greater for past smokers. So pathophysiology, again, we know the demyelination and damage to axons. Again, what we don't know is what triggers that demyelination. And so communication between the neurons is reduced or lost. So clinical manifestations. So symptoms vary depending on the nerve affected, but we can see, for example, numbness, tingling, ataxia, weakness, visual problems, dysphagia, constipation, and bladder dysfunction. So with a long progression, we're going to see inability to write, speak, or walk. And so what we don't know for sure or why it's happening, but so some patients progress rapidly while others have periods of relapse and remission and can maintain a normal lifestyle for long periods of time. So unfortunately, there is no cure, and so we do have our immunosuppressive therapy with corticosteroids and other meds to treat the symptoms, including pain, depression, fatigue, etc. But again, so we're not really having a treatment that treats the demyelination. We're actually just treating the secondary symptoms. As of current, we don't have a treatment for the demyelination itself. So nutrition implications, so the medication side effects, so dry mouth, nausea, vomiting, challenges to meal preparation due to fatigue and weakness. Consistency modifications may be necessary due to dysphagia. And so again, because of this change in these nerve signals, so self-prescribed fluid restriction is common due to impaired bladder control. So there's a risk for UTI and neurogenic bladder. And so again, because of embarrassment due to incontinence, many of these patients will restrict fluids. So weight gain due to physical inactivity is common. And patients often seek complementary and alternative medicine. So again, you'll see, it's very frustrating to me right there. There's no such thing as an MS diet. I wish there was. I wish we could be more involved with these patients beyond the dysphagia. But again, there's no magic diet that's going to stop an autoimmune disease. Now, again, we don't want to encourage inflammation, but again, and there may be individual trigger foods, but there's not a standardized confirmed diet that does convey any benefits at this time. So other nutrition interventions, so again with a focus on inflammation. So again, supplementing with omega-3 fatty acids, again, no clear benefit demonstrated, but with an overall anti-inflammatory effect, again, very little likelihood for any negative side effects. So vitamin D supplementation and calcium, so again, due to the long-term corticosteroid use. With dysphagia, we may need an altered food texture and liquid consistency. Again, a strong encouragement on weight management, so again, these patients are at increased risk for overweight and obesity. Prevention of UTIs, so again, distributing fluids throughout the day, cranberry juice, adequate fiber to prevent constipation, diarrhea, or impaction. And patients may need assistance with meal prep or feeding, and nutrition support, again, to have those conversations early on with the patient and family. So again, looking at that living will, looking at having those decisions made before an emergency strikes. All right, so we'll move into dementia. So a general term for conditions involving loss of memory, impairment in language, judgment, calculation, and problem solving to the extent that it interferes with an individual's life. So Alzheimer's disease is the most common type of dementia, but other types include vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. So Alzheimer's disease, so progressive neurodegenerative disease characterized in the brain by abnormal clumps of amyloid, beta peptide, and neurofibrillary tangles. So discovered by Alois Alzheimer in 1907. So epidemiology, so 5.3 million in the US live with Alzheimer's disease. So Alzheimer's disease is the 6th leading cause of death in the US, affecting 35 million people worldwide. So the prevalence of Alzheimer's disease continues to increase with an aging population. So most cases are diagnosed at age 65 or older. And so what you're going to see is that as the baby boomers retire and as they age, what you're going to see is you're going to see an increase in the amount of Alzheimer's in the population. Now what's happening is it's not that more people per se are getting Alzheimer's. So more total people are indeed getting Alzheimer's, but that's because there are more old people total. The big concern is that, right, Alzheimer's typically, right, takes a long time to impair someone's quality of life, right, leading to death, right, with late stage Alzheimer's, is that it's going to overwhelm the healthcare system in the future because you will have so many more elderly and then so many more patients with Alzheimer's. So the incidence is equal in men and women, and prevalence is 3 times higher in women. So again, it has an equal chance of occurring in men and women. It just affects more women because Alzheimer's affects old people and women live longer than men, right? So it affects men and women equally when the men make it that far. But again, because they usually die from heart disease, etc. earlier, it may look like at times it affects women more frequently. So etiology, so age is the most important risk factor. Now we do have, so early onset is if they're less than 65 years of age, and late onset is if they're greater than 65 years of age. And familial Alzheimer's accounts for about 5% of cases, and currently 3 genes have been identified that cause early onset Alzheimer's. So things that research has identified, so apolipoprotein E or ApoE gene as a risk factor for the development of late onset Alzheimer's. High intakes of fruit, vegetables, fish, and omega-3 is linked with a lower risk, that's a lifelong consumption. Lead, iron, aluminum, copper, and zinc implicated in the pathogenesis, since they catalyze the production of free radicals and induce dementia. Other causes may include damage to the mitochondrial membrane, oxidative stress, impaired insulin signaling, elevated homocysteine, low folate, and high cholesterol. Which I know what you're thinking, which is, so everything. And that's kind of the problem, right, is that we're not exactly sure which of these is most important, which of these is most dangerous, but these are all associated with the development of Alzheimer's. So again, that pathophysiology, so beta amyloid plaques develop, which is the first major change. So plaques clump together and prevent neurons from functioning normally, and the protein called tau forms neurofibrillary tangles within neurons. So tau is required for normal neuron function, but when it clumps together abnormally, right, it ceases to function properly in Alzheimer's disease patients. Plaques and tangles are associated with abnormalities in communication, function, and repair among the damaged neurons, and in shrinkage of the brain as damaged neurons die. So clinical manifestations, this is a very brief overview. So again, this is entire medical courses and specialties. So first stage is characterized by memory loss and confusion. So this gradually progresses to impaired decision-making and language skills, disorientation to time and place, abstract thinking, behavior and personality changes, and difficulty recognizing friends and family. And so these patients will require assistance in their ADLs, so that's right in their bathing, toileting, dressing, etc. And in the final stage, right, the patient's bedbound, with incontinent with contractures, and unable to eat or communicate. So more specific, right, we're going to see, so day-to-day events are going to be forgotten, possessions are going to be misplaced, or appointments are going to be missed. Crystalline memories will eventually go, but they're usually retained for the longest period of time. So again, the longer something's been in our memory, the longer it's usually typically going to last, but eventually they are likely to leave. So we have anomia, so forgetting the names of objects, echolalia, so repeating words spoken by others, and agnosia, so comprehension is mostly lost, which is they can physically hear what you're saying, but putting two and two together and wait, what do you mean? And does it all make sense? Becomes difficult. So for diagnosis of Alzheimer, other diagnoses must be ruled out. So we have what's known as the mini-mental state exam, a neurological exam, an MRI, and a CT. And so the DSM diagnostic criteria, so here we're looking at memory impairment with at least one of the following: aphasia, apraxia, agnosia, and disturbance of executive functioning. But again, to truly diagnose Alzheimer's disease, autopsy is the only way for a 100% confirmation of diagnosis, where we can see the cerebral shrinkage and destruction of brain cells. And so you can see, again, we can see the change, so you can actually see the clumping, right, with the actual tissue. And again, the ventricle space, right, or the fluid-filled space, right, so because of the large clumps, you see then the larger empty cavities within the brain. So the medical treatment, so we have medications, so cholinesterase inhibitors like Aricept and Exelon, NMDA receptor antagonists like Namenda. So these drugs may cause GI side effects like nausea, vomiting, diarrhea, and poor appetite. Psychiatric medications are used to treat associated, or right, these are the secondary symptoms such as agitation or depression. Appetite stimulants to increase intake may be necessary, especially if patients forget to eat. And again, similar to previous conditions, this is a multidisciplinary team approach for the treatment. So nutrition implications, we want to prevent malnutrition, progressive loss of memory affecting shopping, food preparation, and again, remembering to eat. So eventual need for assistance. Again, we're going to see increasing, right, as increasing severity, so chewing difficulty, dysphagia, self-feeding difficulty, confusion, agitation. And so weight loss is common due to pacing, and these patients, right, either not experiencing hunger and or forgetting to eat. So intervention, so supplementation, so diets rich in saturated fat and alcohol and deficient in antioxidants and vitamins promotes the onset of Alzheimer's disease. Diets rich in unsaturated fats, vitamins, antioxidants, wine, curcumin, and some spices appears to suppress the onset of Alzheimer's disease. Garlic may be neuroprotective, resveratrol may be protective, and omega-3s in the early stages being investigated as a possible counteraction to neuronal degeneration. Again, not a magical cure, right, or a silver bullet by any means, but again, very low likelihood of side effects or right things that would make things worse. And choline may be protective of cell membranes. So feeding, so companionship and assistance at mealtimes. So these patients often need reminding or cueing, which is, hey, don't forget to take a bite of the mashed potatoes. And then, right, with repeated encouragement, they'll still maintain intake. Finger foods if motor skills decline. So again, we can actually cut sandwiches, we can cut chicken fingers, etc. to increase intake. So providing fluids, and again, while they're not getting thirsty, you want to keep encouraging. And better lighting and soft music. And so think elevator music, think mood lighting, not trap music, right? And bright lights, right? We want your classic romantic restaurant, right? We want things not glaringly bright, but not too dark. And again, soft elevator music. So limiting distractions and noise at mealtime. So again, very disruptive dining halls, nurses yelling at each other across the room, etc. Right? We want to limit all of that. That can be very disruptive. And visual agnosia, so the inability to recognize food. So again, they can see, of course, that something's in front of them, the fact that it's actually food. And colored china can help differentiate between food and the actual dish. So for example, right, you put a white chicken breast that's just baked chicken on a white plate, it can be very difficult to see. But if we use like a red plate with a white chicken breast, all of a sudden it's much easier for the patient to distinguish, right, that they still have food on their plate. And so diet, again, increased energy expenditure from pacing, modifications in texture and consistency if it's progressing into dysphagia, and then frequent nutrient-dense snacks to deter weight loss with nutritional supplementation and support as necessary. So we can use our standard Ensure, right, our PO supplements, and then nutrition support if appropriate or desired. So here we have a nice little table, so nutrition goals and interventions for Alzheimer's disease and other forms of dementia. So again, maintaining right intake, snacks, making it for an enjoyable experience. It's not too stressful, so easier things to eat, etc. So our practice questions. So if a patient drools, chokes, or coughs during or after meals, has a gurgly voice, and has chronic upper respiratory infections, he or she may have, and that is answer choice C, dysphagia or problems swallowing. In patients with ALS, nutrition therapy should focus on, and this is B, maintaining good nutritional status and optimal function. Patients with Alzheimer's disease often experience, and this is answer choice A, malnutrition. A ketogenic diet may be used to treat patients with, and this is answer choice B, epilepsy. And number 5, drug therapy for Parkinson's disease is sometimes more effective if patients wait until dinner time to eat most of their, and this is answer choice A, protein. And so again, this is just assuming, right, that patients are getting their medication in the morning. But again, ideally, right, you would eat most of your protein, right? Don't have steak and eggs, and then also take, right, your L-DOPA, right? You would want to have your continental breakfast, your croissant, your fruit, your juice with your meds, and then eat most of your protein towards lunch and dinner. All right, thank you for your attention, and I look forward to your questions.